we're going to be talking about vicarious traumatisation of veterinary professionals. So the learning outcomes from watching tonight's webinar, hopefully by the end, you'll be able to feel confident in describing what vicarious traumatisation is, understand why veterinary professionals are at risk from VT. I'm going to shorten it to VT, otherwise it's quite a long thing to say. We're going to understand the triggers and the symptoms of VT in yourself and maybe in other people. And we're also going to explore what can be done to combat VT and move through that towards something called post-traumatic growth. So before we begin this evening's session, it's really important that we just start to check in with ourselves and note how you're feeling. So just take this moment to maybe close your eyes, have a soft gaze towards the floor if that doesn't feel too okay to you, and just do a quick body scan. So I want you to start just focusing on your breathing. Breathing in and breathing out. Now, whilst you're doing this breathing, I want you to just maybe pay attention to how your head is feeling. Once you've done that, just moving down your spine, down your neck, towards your shoulders. Do you need to do any shuffling? Bringing your attention then to your arms. How do your arms feel? Maybe they're hanging by your side, maybe they're on your lap, maybe they're on a desk. And moving back up to your chest. How does your chest feel as you're taking those breaths in and out? How does your abdomen feel? How about your pelvis? Where are you sitting? Are you feeling comfortable? How are your legs positioned? Paying attention to them all the way down to your feet. And just make sure that if you have noticed any aches or pains or feeling a little bit uncomfortable, actually, maybe just shuffle and make yourself as comfortable as you can. Okay, and we're going to begin the session. So I just want to make a quick note about keeping yourself safe. This evening we are going to talk about trauma. Hopefully it won't be too triggering, but we're talking about how it feels in the body and what the consequences can be for us as vets and veterinary professionals in practice. Please keep in mind that we might not always know when something might be triggering for us. So if you do notice at any point this evening whilst we're doing this webinar, you become unsettled in any way, please just reach out to someone who you trust to talk to and come back to watch at a time where you feel less activated. Okay, so first off, what is trauma? So trauma is actually not what has happened to you, but how the thing that has happened to you affects your body and how you feel about it. You may have heard people talk about big T and little t when they're talking about traumas. And I guess this is a way of people classifying how big and how important a trauma was. So a classic big trauma might be a really big car accident, and little trauma might be something that people really consider maybe normal even. But actually, this is not a really helpful way of talking about trauma because it's quite judgmental, and it lends itself to us kind of feeling like we understand how somebody might feel if they've suffered through X and if they've suffered through Z. Trauma is similar for everyone neurobiologically, and we're going to go through that in a second, but different people will react differently to different traumatic events. So again, whilst something might be a really big trauma to somebody and not a big trauma to somebody else, it doesn't mean that we can kind of pass judgment on that or kind of really understand what that might mean for somebody without asking them. So you may have heard of the term being trauma-informed. This is something that we're talking about a little bit more at the moment. Being trauma-informed is something that we can really help us change the way that we work, both day to day, for ourselves, but also professionally. So when we start to work in a trauma-informed way, people around us feel safer and more able to trust in us because we are projecting that we really understand and that we really care about that person's experience. This is beneficial for both the vet team and also for our clients. When we think about veterinary organisations being trauma-informed, this then can be done on such a wider scale. And so this is why it's really important to start having this conversation back in practice. When we're working in a trauma-informed way, as a vet practice, you can actually really improve the client's engagement with veterinary care. Because if we're working understanding where this client is coming from to a degree, then we can actually get them to a place where they're being able to take in more information and really feel like they're working together as a team, which will ultimately benefit our patients, but also benefit us and our job satisfaction too. So the first kind of step in terms of encouraging this post-traumatic growth that we're going to be talking about is really being able to understand how our brains can react to trauma so that we can understand how we can help our brains recover. So this is a very, very kind of brief diagram of our brains. And there are 4 kind of parts of the brain that we're really going to be focused on. We're not going to talk about them after this slide, but this slide's really important in helping us understand what happens to us when we go through something traumatic. So at the top here, we've got our non-traumatized brain, and at the bottom, our traumatized brain. We've got our prefrontal cortex at the front here, and that's responsible for executive control. That's like rational decision making. That's what we're really thinking about when we're thinking about our patients and treatment plans and how we're going to go about the day. We've got our anterior cingulate cortex, our ACC, and that's our affect regulation. We've then got our hippocampus, which is helping us with our memory, so our memory recall and our memory storage. And then we've got our amygdala, which is kind of our panic button. That's where we have our fight, flight, fawn, and freeze. So in a trauma response, what happens is our amygdala comes online really quickly, and that gets us to, okay, what's the safest thing to do here? How are we going to get through this? And when our amygdala is on board, what happens then is our prefrontal cortex shuts off, and so our rational decision making doesn't happen. This is something we can't prevent. If we are feeling under threat in any way, this happens in our brain without us knowing about it. And that's why maybe we can say, well, why didn't this person do this in that situation? That's what I would do. And actually, it might be what they thought they would do too, but at that time they weren't able to. So if we think about the trauma and how that has affected our brains, we can see that actually these sizes relate to kind of what we see on MRI scans of brains. So for the non-traumatized brain, we have kind of an average size prefrontal cortex. We've got an average size ACC, an average size hippocampus, and an average size amygdala. But for our traumatized brain, we actually will see a slower growth on our prefrontal cortex. So we'll have less kind of ability to have control over executive functions. We'll also see a reduced size in our ACC. We see a reduced size in our hippocampus, which is why a lot of people who maybe have suffered a lot of childhood trauma suffer with memory recall and storage. That's because their hippocampus is a little bit smaller. And we actually see a growth in our amygdala because our amygdala has had to grow to deal with the trauma that we've been going through. So if we can kind of understand that that's how our brains actually respond to a trauma, that can all feel a little bit doom and gloom, and that maybe we're all going to suffer forever. But actually, we all understand as veterinary professionals that our brains are really incredible, and we've got this thing called neuroplasticity. And neuroplasticity is essentially kind of our brain's ability to form new neural pathways. So we see this in patients who have maybe had a spinal trauma, and then we start to see them walking again. They are learning to do that. They're growing those new neural pathways or repairing pathways that were there before. And we can do this after we have either suffered a trauma ourselves or been through a vicarious trauma. Neuroplasticity, or our brain's ability, I guess, to do this is influenced by a few different factors. So we can think about stress. That often has a negative impact on neuroplasticity if there's too much stress. Our hormones play a big part. Some medications can affect how our brains are able to heal. Exercise, aging, our diet's really important. The environment in which we're working or in which we're living in. The support that we feel that we've got around us, and therefore our social connection as well, and also neurotransmitters such as dopamine. So that's kind of like the sciencey part of that, and we'll come back a little bit to those factors later on. But for now, I just want to introduce you to something called the window of tolerance. Now, some of you may have heard of this window of tolerance before, and it is kind of a basic way of us understanding where we are at any one moment in terms of our own kind of ability to regulate our emotions and our nervous system. So if we think about our window of tolerance being in the middle, and being a time where we're able to form connections with other people, we're feeling pretty calm, we've got a really good regulated heart rate and breath rate, we're feeling kind of able to take on quite a lot. Something then might kind of trigger us into becoming either hyper aroused in fight or flight, or hypo aroused in flop, freeze, or fawn. And so either of those is kind of an option for all of us, but we tend to kind of have one that we more often go into than the other. So a lot of people will more often feel very anxious and feel very hyper aroused with this fight or flight. And a lot of people, their kind of go-to system will be that flop, freeze, or fawn response. And depending on what we've got going on for us at the time, we have a wider window of tolerance or a smaller window of tolerance. So you can imagine that if we're feeling less able to cope with the things that's happening around us, our window of tolerance might be quite a lot smaller. And once your window of tolerance is smaller, then actually it doesn't take a lot to tip you into one of the reactions that we've got there from our amygdala. And alternatively, we might actually be feeling like we've got a really wide window of tolerance. We're feeling really okay, really settled. Things are going really well for us. And so it takes quite a lot more to go wrong before we feel in a certain way around it. Okay, so what is vicarious trauma? To do something vicariously is to kind of experience something through somebody else's eyes, essentially. And so before we can understand what vicarious trauma really is, we have to just kind of work out what it isn't. So PTSD, which is our post-traumatic stress disorder, was first recognised as a condition in around 1980. And then by about 1995, people had started looking into the effects of trauma on people, both firsthand, but also secondhand. So people hearing of other people's traumas or helping people through traumas. And that was actually when they first coined the term compassion fatigue, which I know that we all will have heard about. That's something we've been talking about in the vet industry for quite a long time now. Some people will use these terms interchangeably, and there are other names that we might kind of hear that kind of come under this umbrella, but they are actually different. So I just wanted to kind of outline why. So compassion fatigue is when an individual is in a caring capacity and they are overwhelmed by those high emotions really regularly and ultimately have reduced empathy as a protection mechanism for that. So we do see that in the veterinary industry. We do see that once we're feeling really overwhelmed with how much we've got to give of ourselves, that maybe we start to feel like we care less. We might also hear the term burnout, and this is when an individual has physical and emotional exhaustion caused by cumulative effects of high stress. And these tend to be people who reach out for kind of unhealthy coping mechanisms, such as maybe over-exercising, turning to alcohol, eating, etc. Another time we might hear burnout, in which is used quite a lot at the moment, especially is with neurodiverse individuals. So you might hear that somebody with ADHD or autism has been through kind of a really tough day of masking potentially their symptoms, and actually they just feel burnt out. They're no longer able to kind of mask those social things that they do every day in order to fit in. The term secondary stress can also come under this umbrella. That's when we witness either a traumatic event or surviving a traumatic event. So this could be your typical car crash. So maybe you've witnessed it, you've been involved, but you've been okay. And you might have something called survivor's guilt. With secondary stress, there tends to be an element of guilt and an element of fear with this. So for secondary stress, you might not be impacted on a really wide scale, but you might find that actually every time you get in your car, you start to kind of feel a real bodily response. Or every time you drive down that road, you start to feel really panicky. And that can be the result of this secondary stress. And with vicarious trauma, what we actually start to see is a very, very gradual change for somebody who is repeatedly exposed to traumatizing events or stories, which leads them to having kind of a more negative view of the world and their beliefs, which can ultimately kind of lead them to have difficulty functioning in all areas of their lives. We know that when we're with somebody in close proximity, our bodies will sink into similar biological patterns. And this is true for humans, so human to human and also human to animal bonds. We know this because obviously when we have pets, we know that that can reduce our blood pressure. And so we know that if trauma isn't what happens to you, but it's what happens to your body, then actually this kind of close proximity that we can have in syncing biological patterns can both really help us with vicarious trauma, but also put us at risk. If you can imagine being in a consultation with somebody who is really, really going through something, maybe they have been really traumatized at home, a lot is going on for them, maybe they have had really bad news about their pet's illness, and they're feeling very, very physically unhappy and stressed, then actually we can take that on. That can increase our chances of feeling traumatized by that experience. But actually, we also have the ability, if we're able to regulate ourselves and feel in a good position ourselves, to help regulate. We can't take it away from them, but to help regulate them by being in close proximity to us with our calm nervous system. It's really important that we just hold on to, we're really good at what we do because we're empathetic. So you are a good veterinary professional because you really care. And empathy is different from sympathy. Empathy is being in that with somebody, understanding the feelings that they're going through because you really care. But that same empathy is what opens us up to vicarious trauma. But if we can start being more aware of the risk of VT, recognize symptoms in ourselves and also others, and then work towards this vicarious post-traumatic growth, then it can actually be really beneficial in protecting us as we move forward and kind of making our careers much more sustainable in the long term. So how does it happen? We've spoken about this a little bit, but by empathizing essentially with somebody explaining or describing their traumatic experience, we might get it from seeing videos of traumatic experiences. We might have this from hearing victims talk about their experience, reading files of traumatic cases. So that person doesn't need to be in the room with you. You could just read it. We have this with people that are responding to mass incidents and seeing traumatized individuals on a really mass scale. And also if we take part in something traumatic for another being, be that a person or an animal. And so obviously in the veterinary world, that kind of plays a huge part. So why are vet professionals at risk? So although tonight's webinar is going to talk quite a lot around kind of the core veterinary team, it's really important to be aware that actually any of us are going to be kind of at risk of VT at some point in our careers. So the front of house team are not immune to this. Often you're the first people speaking to carers on the phone with emergencies. And actually, especially if you're new to the job or you've not had any kind of teaching or learning on the job yet, this can really actually evoke that kind of freeze, like, oh, help, I don't know what to say to this person who's asking for advice on the phone. You're also trying to fit patients into this long consult list who need care when you have a really full diary. And you kind of then are torn between this patient who you can hear on the end of the phone really needs to see a vet, but also feeling bad for the vet or the nurse that you've booked into maybe their admin slot, their lunch break, maybe you know that they left late yesterday. You're also going to potentially be the first responders when clients or members of the public arrive with injured pets or wildlife. You're also building relationships with long-term clients and their companions. You're really like understanding the families, you're hearing all of this, you're kind of really becoming very involved because you care. You're often dealing with really difficult financial conversations, and those in themselves can be quite traumatizing for people. And you might be reading and maintaining client records. And again, we know that we don't need to be in that consultation. We can just read those notes, and that can be traumatizing in and of itself. So then also our auxiliary team, so maybe our patient care assistants or our VCAs, you're assisting with the nursing care of inpatients and potentially some surgical skills and surgical prep as well. So you're being really in the midst of maybe some really potential difficult cases. You're obviously going to be assisting with euthanasias and end-of-life care, and that can be really hard to do on a kind of ongoing basis. You might also be taking on front of house responsibilities. So be again that person who's dealing with the emergency when they first arrive in reception, or taking an advice call on the phone. And just like the front of house, you're doing this with potentially much less background knowledge than a lot of the vet team. And whilst that can be a protective factor in some ways, so maybe you're less likely to have moral injuries, it can be a risk factor as well, because you can feel like, oh, I don't know what to do, and that can be quite distressing. So then our vets and our veterinary nurses, you're going to be involved in potentially traumatic consultations. So they might include animal injury, animal abuse, accidents. Our euthanasias can be traumatic for pet carers, and they often are. And so being that person to perform them regularly can be really stressful, especially if those are really difficult circumstances for that carer or for that pet or for you. You're going to be empathizing with those clients' stories, you're caring for patients who are suffering, and then sometimes you might even be caring for a patient who's suffering against your own kind of moral judgment. Maybe you have that feeling of, if this was my pet, I would do things differently. And that can cause us this moral injury, which we don't have time to talk about today, but is a really kind of big risk factor when we think about vicarious trauma. So what contributes to the size of our window of tolerance? So if we're always holding our window of tolerance in mind, we can have like chronic or lifelong contributing factors to that. And we also will have acute contributing factors too. So we'll just go through those. So education can be a big factor. Our lifestyle is a big factor. Our kind of emotional resilience, I guess, is a big factor. If we are neurodiverse, that's a factor. And also something called our phenomenology, which we'll come on to. So with education, the veterinary world is a very small one, and it's very competitive to get in. So often our vets especially are really set up from the beginning to be very, very top students. You're probably used to being somebody who has got a lot of things right. You have worked really, really hard to get your top grades in order to be considered for uni. And then you've gone into uni and you're full of people who have all been the top students and tried to get into uni. And so suddenly maybe you're not at the top anymore. And medicine is not always right and wrong. There's so much grey. And so maybe you've gone from being at school, which with kind of our education system is very much set up for rights and wrongs and getting things right on a test, to something like medicine, which actually maybe there isn't a right or wrong. And there's so many extra factors that it can really be murky about what is the best thing to do. You're also in high pressure environments from the minute that you start university to when you're working. So university is high pressure. You've got to pass lots of exams. In your time off, you don't have time off. You have to do EMS and work experience. And then you go into work. And again, that's a really high pressured environment. And there's these huge expectations on learning in a very short period of time. When we think about our emotional factors, as we've talked about, we all have high levels of empathy as a profession. And that might be for both people and animals. It might be mostly for our animals. But that high level of empathy is a risk factor in and of itself. We have often this mind-body disconnection. Part of the reason that in the beginning of this webinar, we did that very short kind of body scan breathing exercise was just to get you to pay attention to your breath and also to get you to pay attention to your body. I'm wondering how many of you, as you were doing that, actually realised that you haven't really checked in with your body at all today or this week or ever. And some of this mind-body disconnection is a protective mechanism for us doing our jobs well. And so that's great, good. When it works, it works. But actually, it can be quite damaging in the long run if we don't understand it and notice it and do something about it in the sort of downtime when we're at home. We also have high perceived responsibility for patient outcomes. And I put perceived because whilst I understand there is a high responsibility for patient outcomes, especially on the core vet team, actually there's lots of other factors in that too. We need our carers to be on board. We need our pets to respond in the right way. A lot of them don't read the textbooks. And so this responsibility for the patient outcomes might feel like it all sits on your shoulders, but actually it doesn't. There's high levels of imposter syndrome in the veterinary field as well. That's when that little voice kind of says, oh gosh, any minute now, somebody at work is going to realise I don't know what I'm talking about. And actually, you do know what you're talking about. You've got there for a reason. You're very good at your job, but you don't know everything. And that's okay, because none of us do. So kind of understanding that imposter syndrome is a thing. And actually, a lot of us have it, is a real game changer in being able to hopefully try to get that voice to be a little bit quieter at times. And then also acute emotional changes too, because life happens. So we might be somebody who's really emotionally resilient, but then we suffer a bereavement or we suffer an accident ourselves, and that kind of puts us on edge and that shortens our window of tolerance, and that's okay. That's just being human. So our lifestyle factors can also come into this too. our window of tolerance is going to be bigger if we're able to do things that like fill up our cup, is kind of a saying that I used to use. So with our lifestyle, often in the veterinary world, we work really long shifts. Often there's out of hours involved, kind of antisocial hours are involved. We have a reduced capacity because of that to be able to like join clubs. So if you're somebody who really wants to go and play hockey, or you want to do pottery, actually it's really hard to get that time to do it if that is every Tuesday at 6 p.m. and you know that you can't guarantee to make every Tuesday at 6 p.m. That can be quite restricting. The salaries are often not in line with how much of your life you're giving up to do your job, and to do your job well. Your social life can take a little bit of a back seat, especially when we're really passionate and we're beginning in this career, but also as time goes on, if we're really tired, we're working these long shifts, we just don't want to see anyone. And so social life can really kind of suffer through that. And then we all know that diet and exercise play a massive part in us feeling well, for so many reasons, but especially for this neuroplasticity. But actually, if you are working long shifts, you are very tired, you're working lots of overtime, your diet and exercise does fall by the wayside because you can't do everything all at once. There are also going to be some organisational elements here as well. And we'll touch again on organisational input a little bit later, but things like the team dynamics are going to have an effect on how tolerant you feel, so like how big your window of tolerance is that day. The consulting expectations that are placed on you, depending on where you work, you might be in a place where it's pretty relaxed and it lets you kind of have some autonomy over that, but you might be in a place where the consult times are really short and maybe you've got lots of limits on what you can do and how many people you have to see. And again, with imposed targets, if you feel like you're having to reach a target all the time, that can put a lot of extra stress on you. Working preferences balanced with expectations, again, can be a real difficult one because we all have to do a job in order to for businesses to do well, and we're all working in businesses. But it's also important to maybe be able to take some control over what you're doing where you can. So then neurodiversity, and this will shorten a lot of people's window of tolerance. So if somebody feels that they come under this ND umbrella, then actually they are more likely to have kind of a smaller window of tolerance than somebody who is maybe neurotypical. When we think about neurodiversity, often we think about ADHD and autism. They are things that are talked about a lot, especially at the moment. But actually, there are many, many other conditions and disorders and things that come under this umbrella of neurodiversity. Things like clinical depression, anxiety disorders, post-traumatic stress disorder, they can all come under neurodiversity because, as we know from what we talked about with our neurobiology, they actually do all have an effect on different areas of our brain, and different parts of our brains work in different ways and in different speeds. If you are neurodiverse, then maybe you struggle with societal norms and reading social cues. You might find the veterinary practice to be quite overstimulating. It's very loud, there's lots of lights, there's lots of animals everywhere, lots of people talking. And this can be really hard to kind of focus because actually, where a neurotypical brain might find societal norms just really kind of automatic, somebody who isn't neurotypical might actually be using a lot of energy to do that and to read people's expressions. And so actually you're less likely to have a wider window of tolerance, especially if there's other things going on outside of this. Phenomenology is a really interesting concept, and it's basically the philosophy of experience. The reason I've put this on here is because we have all got different experiences of the same things. The best way I can describe this is that you can take two identical twins, raise them in the same way by the same people in the same environment. And when you ask them their individual experience of something they both did together, their experiences are going to be different. And that's because they are unique individuals. So whilst they might be identical twins, they have different brains, they have experienced something in a different way. And so when we think about how we talk about trauma and how we cope with things at work, there's a lot of judgment always on, I would have coped like this, or this happened, but back in my day, it was like this. And whilst that might be very true for us, we don't know how that person would have dealt with it. And so just kind of holding in mind that phenomenology is a thing and that we all have very different experiences, despite maybe on the outside looking quite similar. So those are kind of the main factors. The other one that I just really want to mention is if you are within a marginalised identity, because we know that marginalised groups are at higher risk of vicarious trauma across the board. So if you are from a marginalised race, marginalised gender or gender expression, a sexuality, you have a disability, whether that is a visible one or not, refugees, you're all going to be at higher levels of risk for vicarious trauma. And on that same wavelength, the role of culture has been studied in post-traumatic growth. The role of culture can play both a positive and a negative here. So there can be a risk factor depending on what culture you are from. If you have sustained traumas either personally, culturally, recently, or further back in history, way back before you were born, that's something we would call generational trauma. And if you're from a culture where there has been a lot of trauma, then you might feel like trauma is inevitable and you may have a more negative worldview. However, cultures which have a more protective factor in the role of post-traumatic growth are those cultures where there's a really strong emphasis on family, connection, shared responsibility. So for Hispanic cultures, for example, actually, they really rely on each other. They're very open about talking about things. And they've shown that in Hispanic cultures, they have more propensity to develop post-traumatic growth than feel vicariously traumatized than in those cultures where there's a lot of individuality. So for Western cultures, we're very independent. We don't need other people. What do you mean? I want to go and talk to somebody. I can cope myself. And actually, that is a culture where we're at much more risk of having vicarious trauma. So if we take all of these things into account and we hold them in mind, I've just got one case consideration really here. If we have a client who arrives with their elderly dog for euthanasia, you've been treating them for months for worsening severe osteoarthritis, and all of your analgesia options have now been really exhausted. The carer has been hugely invested in doing everything they can for their companion, and they really know this is the right time for the euthanasia to happen. You know that the carer recently lost their partner and they've been confiding in you during regular patient checkups about how lonely they are, how much they're dreading this time, and how they don't know if they're going to be able to cope. If we take that case consideration, and I'm sure that many of us, if not all of us, can think about a time that is very, very similar, if not that exact case, then depending on how we're feeling at the time will depend about how much we tolerate or how much we cope with that, and the risk that we have for that kind of situation to become something that we might find quite traumatizing. If we take into account our education, our lifestyle, if we're neurodiverse or not, emotional kind of resilience, whether that is long-term or if something has happened recently, if we feel we are part of any marginalized group, how we just are as a person, depending on what day that client comes in with this story, is going to depend on how we feel about working with them, how we're going to move forward from this. We might hopefully have quite a large window of tolerance if we've been looking after ourselves and doing everything that we can to kind of essentially check that we are feeling all right. But actually, if we're having a really difficult time, and a lot of that time is out of our control, and our window of tolerance is very small, then we're much more likely to kind of be tipped into one of these and feel traumatized, whether we know about it or not. Which brings us on to what does it actually feel like? This is going to be different for different people at different times. When you check in with yourself, where do you feel anxious? Now, when I work with people and I ask them this question, a lot of the time, veterinary professionals kind of look at me blankly and say, what do you mean? And I mean, where do you feel it in your body? Some people will describe anxiety as like a tight chest or somebody sitting on their chest. They might describe it as butterflies in their abdomen. They might describe it as like tingly fingers, tingly toes. Maybe the kind of their head goes very silent. This is very different for different people. So where do you feel anxious in your body? We know that one-off situations may upset us, and that's okay. I think that actually any of us with that client coming in, we're going to feel upset, and that's all right. That's normal, that's human, that's empathizing. And actually, as a professional, you have already developed really good ways of working within your kind of competency. And so lots of these things, whilst they might be really sad, are not going to cause you any issues at all. However, we might find ourselves feeling uneasy about repeating the same thing again. So we might then start to avoid things kind of more longer term if they remind us of a specific case. And when I say remind us, that might not be a conscious thing. It might be, oh, there's a funny feeling that I'm having in my body, and so I'm not going to do that again. And that might be happening completely unconsciously. It's more likely that as a scientific person, as a vet, as a veterinary nurse, as a veterinary professional, you've lost touch with your mind-body connection and you just don't feel that. And actually, that's not okay, because you have developed it as a coping mechanism. And at the time, that might be really, really helpful. So when we are going from a euthanasia to a puppy vaccination consult, it's really important that we have some kind of disconnection to do our job. But in the long run, we need to make sure that we're not losing touch with ourselves completely. So now we're going to look at a few kind of symptoms, I guess, in what VT might look like in ourselves or in other people. And I want to take this moment just to remind us that vicarious trauma is a gradual change for somebody repeatedly being exposed to traumatizing events or stories, leading to an overall negative change in their worldview and beliefs and difficulty functioning. So some of these things you're going to recognize in yourself, oh, that was me yesterday. That doesn't necessarily mean that you're suffering with vicarious trauma, but it's to be aware of, is that something you were kind of suffering with yesterday and you felt like that yesterday because of X, Y, Z, and today you feel very different? Or is it kind of starting to become a pattern where you're noticing more of these things and noticing more and more that actually you've got this negative worldview? So the first one, and I know that we can all kind of associate ourselves with all of these probably at some point, is our over-involvement. So this tends to be somebody who's really throwing themselves in at the deep end. You are doing everything for everyone. You are working all the overtime. You're slotting in the extra consultations in your breaks. You are maybe even dropping off the medication for the carer whose car is broken down. You're really kind of going above and beyond. And whilst above and beyond is a great trait to have in a lot of ways, actually, if you find yourself doing this all the time, then it actually can be a little bit of an avoidance tactic. And it can actually be very, very high stress, and maybe you're not looking after yourself. And so that can be a sign of vicarious trauma. Anger, rage, and blame. I also think about frustration in this one too. So I'm sure we've all been there, or we can think of somebody who we know that actually if we approach them about a patient handover, or we approach them about something that's happened, their immediate reaction is going to be this anger, this rage, this blame. We might even hear blaming of our patients' carers. We might hear, well, this is their fault. Well, of course this is going to happen. That kind of narrative from them. Whilst this might not be vicarious trauma for everybody, it really is a very big red flag for somebody who is not coping in some way. We can also think about this loss of hope, an increase in pessimism or cynicism. And again, I'm sure we have all been there at some point. But if we know that maybe every single time you speak about patients' treatment plans to this person and they are cynical about it, oh, there's no point in treating that because they all have a bad outcome or something along those lines. This kind of repeated pessimism is a really big red flag for vicarious trauma. And it's actually kind of, I guess, associated a lot with compassion fatigue, but this negative change in worldview, or like, oh, they never get better, like this change in their beliefs. Guilt, shame, and self-doubt. So again, thinking about this imposter syndrome. Imposter syndrome is very common. It doesn't mean you're vicariously traumatized. A lot of us have imposter syndrome from university, from school. But this feeling of, oh, this was all my fault, or, oh, because I'm such a bad vet, this happens all the time, or I'm never any good and I don't know what I'm doing. This is a negative worldview. It's a negative self-view as well, and can also be a good sign of vicarious trauma, especially if this isn't something that this person has kind of always lent towards. If actually you've noticed this change in someone and they're talking a lot like this, then that can be a big sign. With all of these, a loss of boundaries. So thinking back to that over-involved person at the top of this, that's a loss of boundaries. If you are answering your phone on your days off, if people know they can contact you about blood results on your annual leave, that's a loss of boundaries. And there is a difference between being a really helpful colleague who kind of knows their stuff and is happy to help, to not actually looking after yourself. Because if you are losing your boundaries, actually that can start making you a little bit annoyed. And actually you can get annoyed at everyone for pushing your boundaries, but if you don't hold any of them up yourself, then that's something that you have to look at for you. Avoidance, again, is another one. And like I mentioned a few slides ago, this might be something that's conscious to you. You might have the decision to say, I can see that this patient's coming in and the last time their carer was really difficult with me, so I'm going to avoid them. It can be a conscious decision like that, but it can also be an unconscious decision. It can be a feeling that's happening in your body that maybe is causing you to avoid something because it doesn't like that feeling. And so kind of being aware of yourself and what you are doing, what you're not doing, who you might be avoiding. And again, this mind-body connection can just help us in kind of noticing what we are doing. So that's kind of vicarious trauma and what that might look like, but how can we kind of move forward into this vicarious resilience or this post-traumatic growth that we talk about? So if we think back to that neuroplasticity and we think back about those influencing factors, we can kind of divide them up into things in our control, things out of our control. Things out of our control that we're not going to talk about today are aging, sadly. Neurotransmitters, so neuromodulators like dopamine, whilst they might be somewhat in somebody's control because they can be affected by medications and things, they're pretty much out of our control. The things we can control that we are going to look at, so we know exercise and nutrition, social connection and support. And then in the middle, we kind of have this grey area. So medications and hormones, the reason they're in the middle is because whilst we don't have full control over those, we maybe feel like we play a part in deciding what medications we take. We might feel we play a part in changing the dose or working out and advocating for ourselves if something isn't working. We can also experience stress. And again, this is something that we do have a lot of control over, but not full control. So when we think about stress, sleep, and our environment, these are all things that we do have a hand in, but again, it is also organizational, it's also societal. So making sure with sleep that actually you've just got really good sleep habits, we call it sleep hygiene, making sure that that's as good as possible, because then you're doing everything within your power to get good sleep, even if it's kind of out of your power for another reason, and maybe that's hormonal. Your environment's in there as well. And the reason that's in the middle is because you can't necessarily change all of your environment. But a good example of where you maybe can make changes is if you're in a consult room that you use all the time and it's yours that you use a lot, if there are small changes to that consult room that you can make that make it more comfortable for you, especially if this is coming from like a neurodiverse approach, then actually, as long as that's okay with other people, that's the type of thing that can maybe just help you in your environment feel as comfortable as you can. So the first thing that we actually do have quite a lot of control over, but it might take us time, is not internalizing patient or client stories as our own. Now, when I say this, there might be some of you that read that and think, that's not me. I've never done that. I don't recognize that in myself at all. And actually, maybe I've judged other people for doing that. Maybe I have seen somebody really take something to heart and not understood why. But there might also be some of you that really do get this and you see yourself in this, because maybe there have been patient or client stories that have really, really affected you and you felt really upset, almost like they could be you or your family. If that is you, then questions for self-reflection into this area might just be, what part of this client story resonates with mine? Who does this person or patient remind me of? What values do I have that I feel are being like conflicted here? So maybe your core values as a person are feeling kind of on edge. What is your lived experience of that particular situation? Once you've kind of reflected on those, I'm sure that there will be some answers that come up for you, but reminding yourself that that's not your situation. You are just playing a part in theirs. And that's the difference between empathizing with somebody and feeling okay about that, you know, moving forward through this post-traumatic growth and suffering a vicarious trauma. We can develop more self-awareness. So doing regular self-check-ins. I know that when we started this at the beginning and we did that check-in, some of you won't have maybe ever done that. Some of you definitely haven't done that today. So making sure that you just check in with yourself. It doesn't need to be a long process, but just, how am I feeling? Quick body scan. Oh yeah, okay, I've got an ache or pain, or maybe I feel a bit cold, maybe I need to do this. Just something. Some self-reflection after difficult consultations or interactions or conversations or conflicts are really good. So kind of, why did I react like that? How, do I always react like that? Even asking other people, maybe if they notice if you always react a certain way, and maybe just questioning why. If you feel inclined, then maybe journaling your felt bodily senses each day, because that can kind of help us really just pinpoint what's happening for us kind of over the longer term. How are your stress levels? Do you feel upset by anything that's happened at work? Is anything at home really difficult? How is my body feeling? What went well today? What could have gone better? Why? And that being said, want you to just take a moment and see how you feel right now. Compared to how we started at the beginning, are you still feeling comfortable? Do you need to move or shift? Are you starting to feel thirsty or hungry? Like those disconnections of, oh, actually, I am really thirsty. That's the type of thing that we need to start drawing more attention to. And good ways of doing this are to do some grounding exercises. So just in this top corner, I've got a few written down. We don't have time today to do them, but just a quick Google, or we can send this out afterwards as well, just to be able to find something that works for you. So maybe doing a breathing exercise such as box breathing, maybe doing body scans more regularly. You can find mindfulness meditations, lots that you can pay for, but also lots that you can find for free. And something called the 5-4-3-2-1 exercise, which is something I do with people who are feeling really high levels of anxiety. It's a way of resetting our nervous system, telling our nervous system that we're safe, that we're okay, to try and help prevent panic attacks or recover from panic attacks, and just to kind of remind ourselves that we're okay in our bodies. Another thing that we can work towards is setting more realistic goals and having realistic expectations. So both in work and home, try not to set yourself too much to do at once. You might not attempt any of them if the list is really long. So especially for lots of people who are neurodiverse, if you write a list of things to do, actually just looking at that list can be so overwhelming that you don't approach any of them. And if you don't approach any of them, then you feel like a failure, like you've not done them. But if you just set yourself a goal that is more realistic, well, actually, today I can do this one thing, then you're much more likely to attempt it and do it successfully. And then you're much more likely to do the next thing too. So just making sure that you understand what your own limits are and what you can actually do within a realistic time frame. I've put here avoid magical thinking, and magical thinking is a term that we use in cognitive behavioural therapy. It's something that we often will start doing as a child. It's a very immature way of thinking, which is very, very normal for us to do as children. It can start as, oh, if I have this thought process, this thing will happen over there. And of course, we know there's no evidence for that. If you think something, that thing over there isn't going to happen. But actually, it can be something that we start to carry with us into our adult life, which can actually bring us a lot of difficulty. This perceived kind of patient outcome, this magical thinking that we have kind of a bigger part in that outcome than we do, can actually be really troubling for us. And so if you find yourself kind of having lots of thoughts like that, like, oh, actually, if I do this, this always happens, then maybe some CBT exercises might really help you. So being heard, I was going to call this be involved when I wrote this slide, but then I thought about that over-involved person who is maybe suffering with vicarious trauma. And I don't mean be over-involved at all, but what I mean by be heard is that often when we are feeling overworked, we can see ourselves like maybe taking a step back. I think especially once we've started to maybe be a bit pessimistic, or if we're feeling quite angry about something, or if we're feeling a lot of blame, especially if it's work related, there can be this, oh, I'm too busy and I'm too overworked and I'm just going to do the bare minimum. And whilst at some times that is actually really helpful for us because we need to have some boundaries, actually it can be really, really good for us to get more involved at work, both to vary what we're doing day to day, but also to feel heard. So often I think about championing something that you're really passionate about in practice. So maybe this is something that nobody else in practice is kind of taken on as theirs. And if you can do that and tailor your CPD to that, maybe even just for a year, that means that when you come back after your CPD, you can maybe share that with your whole team and really feel like you're influencing people and making good changes that are beneficial. It's also really good to start attending team meetings where you can, because again, you can bring in these changes that may have a positive effect both on patients, your team, yourself, patient safety, team morale. And actually, by taking these things, maybe not all of them are going to be taken forward, but you're giving yourself more of an opportunity to be heard. And you are giving yourself an opportunity to see a wider structure of how changes happen and why they happen. And being kind of part of all of that can really help us with that that negative worldview that we're talking about when we think about vicarious trauma. It can help prevent that if we understand that lots of people are doing things for the right reasons. So I'm sure that you've probably all either heard of debriefs or hopefully do them already in practice. So debriefs are like a chat that we have as a team when something's happened. So we have these hopefully after serious incidents that are more obviously traumatic. And I'm thinking about maybe CPRs for a patient who's crashed. You take a few minutes just to say what happened, what went well, what did we notice, what didn't we notice, what could we do differently? Were there any kind of logistical difficulties? Was it really hard to get this patient onto an ECG? Did they have an IV in place? All of these things are really important in a debrief. But actually, these debriefs can happen around other things too. So maybe just after a polytrauma case presentation, like an RTA CAT, maybe after we've been dealing with an angry or abusive client, if we have had maybe a patient in that we're concerned about a non-accidental injury, if a patient's had a really sort of horrible accident or a near miss, then these are all opportunities where we can get together really briefly and just talk about how it has happened and how we're feeling about it. It's also something that we can do after euthanasias. And I think that it's important to kind of think about that for euthanasias, because whilst lots of euthanasia is part of our day to day, and lots of us are very used to that, and we don't feel like we are suffering from that, actually there can be lots of euthanasias that maybe we do notice that that's really got us in a different place than usual. And actually they can kind of feel this, oh, I can't talk about that because it should be something that I'm really good at and something that I'm really used to. And so if I'm struggling, then maybe that will be a sign that I'm not coping or I'm not good at my job. But actually having a debrief after euthanasia is really good, and can really help us through those cases that are more traumatic. And we can also debrief after just unexpectedly long or difficult days, whatever that reason might be. So then again, thinking about this neuroplasticity and support is something that can really help benefit us. So peer support, checking in on each other, I'm sure you do anyway, socialising with each other when you feel like it and if you want to, bringing joy to each other's day when you can. Lightening the load, if you feel like your window of tolerance is at a really good place, whether it's just a day, a week, or for any longer, if you're feeling like you can recognise maybe a colleague who is struggling, maybe their window of tolerance is much smaller, whether they've spoken about it to you or not, then maybe just see if you can lend a hand if your window of tolerance is larger. And then supporting each other in team meetings as well. So attending the team meetings, but also backing each other up if there's something that you want changed. Something that I like to talk about a lot is supervision. And supervision is a clinical expectation for loads of people in caring professions, myself included. So therapists, social workers, psychiatrists, we are all actually mandated to have a certain amount of supervision every single month in order to stay registered with our governing or supervising body. There are many, many reasons for that, and we'll talk about that in a second. And I do know that informal supervision of clinical cases happens a lot within veterinary clinics. So it's not like there's no supervision happening at all, but formal supervision doesn't yet happen in veterinary practice. And actually, formal supervision would really help us with vicarious trauma and vicarious growth, because it would provide set opportunities to talk about cases and themes and any difficulties with somebody with more experience. The reason that supervision is really encouraged and actually is mandated in caring professions is that actually it really encourages our education, it encourages clinical growth, it encourages self-reflection and emotional intelligence, it helps us develop relationships and understand how to deal with conflict, it can help us with this post-traumatic growth, which then actually negates the impact of vicarious trauma. So if we can stay on top of supervision, use it really, really well, and talk about things that we maybe are finding difficult, actually it's our supervisor's job to point out the things that maybe we don't even recognize are difficult. And that's why I talk about supervision a lot, because I think it's something that would really be game-changing in the veterinary industry. So then I want to touch on organisational impacts. And I know that for a lot of you, you're not going to have any say in what happens in your organisation, and that can be really frustrating in and of itself. But in case you do have any impact, or you're ever in a future position to have an impact in your organisation, I want to run through a few ideas that actually are going to help people reduce their risk of vicarious trauma. We know that being trauma-informed is a really good stepping stone for this. Another thing is going to be organising protected time for people to have one-to-one or group supervision. So that can be across the board, not just vets, but being able to have those little debrief sessions is good. To have protected time is better. To look at having a balanced caseload for people, so listening to types of cases that people enjoy or find more difficult and balancing that, or listening to people if they're struggling with something personally so that they can take a little step back if they want to. Thinking about impact of moral injury, so organisation rules that people have to follow that maybe directly clash with their own judgments or preferences. That's, again, something to talk to people about, talk to individuals about, work out what people are really struggling with and what might help them. Just understanding that the organisation can have a huge impact in how people cope and actually how sustainable it is for them as individuals, but also for them in the profession. And definitely to start tackling this is how it's always been mentality for so many reasons, but also just from a trauma-informed point of view. Another point I just wanted to touch on is that it has actually been shown that if you have a reduced capacity to make decisions in your job, so if you have reduced autonomy, then that can actually have a direct impact on how you feel in your role, your respect for your line manager, and also has a direct correlation to your absenteeism for sickness. So whilst lots of control has to be organisational, there is also a lot of there's a lot to be said about micromanaging and allowing people to trust that they are professional, that they're able to do their jobs and make decisions for the benefit of themselves and maybe their patients, their clients, their team, that will actually really help us in reducing even absenteeism as well. So then we're just going to touch on lifestyle. I'm not going to talk about exercise and nutrition because we all know how important that is, and making time for all of that, moving your body in some kind of way that you find enjoyable is really, really good. I want you to start listening to the inner you. What did you love to do as a child and how much time do you spend doing that now? Take time to do it. Go and be selfish. Peer support, so organise regular group supervision to go over difficult cases, not just clinically, but emotionally, and listen to yourself, listen to others. Group supervision is really one of the most effective things in preventing vicarious trauma. And actually, until we're at a place where organisations are recognising that and implementing time for you to have that protected, it doesn't have to be set by your practice. So if you have a group of people, a group of peers who are really kind of willing to take this on with you, then making sure that we are respecting GDPR and confidentiality, of course, but just chatting about the things that you're finding difficult, the things that you've really enjoyed, and talking about it in a more than clinical sense is something that's going to be really good and beneficial for you. A little note about therapy, because I wouldn't be a therapist if I wasn't going to mention it, but having therapy, either individual or group, just something that will enable you to do some self-exploration. And if anything this evening has come up for you and you've thought, actually, this maybe is something that I could do something about, then therapy is a really good place to start with that. I know that we always have lots of empathy in the world for our patients, but I'm wondering how much compassion you have for yourself. A lot of the time I hear about this negative self-talk, this kind of internal bully that we have telling us that we can't do it, we're not good enough, we're not going to be able to do that, nobody's going to listen. And actually, compassion is really important and it needs to start with you. So there's a link here and it will be sent out maybe in the chat afterwards to a compassion-focused therapy course, which has been designed for veterinarian mental well-being and released by Vet Mind Matters pretty recently. So just to recap, Being trauma informed is really helpful for ourselves, for our teams, for our clients, and for our patients. And whilst vicarious trauma in some capacity is inevitable for us in the vet profession, it is something that we can actually utilise to grow. Post-traumatic growth is both an aim and a preventative measure in and of itself in helping us avoid being traumatised vicariously again. And there are a lot of influencing factors within our control to do this, which we've covered today. So by caring for yourself first, you can then best care for others. Hopefully now you understand what VT is, understand why we're at risk, we understand the triggers and potential symptoms in VT of yourself and others, and explored and hopefully understood what can be done tomorrow to combat VT and move towards that post-traumatic growth. Thank you. I hope you've enjoyed.
Thank you, Katie, for a really great presentation. We're ready to take any questions if anybody would like to ask anything. You've got the Q&A section in the panel bar if you want to type anything. And Katie can spend a few minutes answering any questions. We do have a couple of questions already, which I'd like to ask. So Katie, what do I do if I recognise some of these symptoms in my colleagues?
So if you have thought while watching that, I've got somebody that's springing to mind, then I think the first step would be to approach them if you feel that you can. And when you're approaching this person, I would go from a very explorative angle. This isn't about diagnosing somebody with something. It's not about judging them for it, but it's just about being curious. So just maybe being able to make time for them, take them to the side, ask them what's going on for them, if they're okay, maybe kind of saying, oh, I've noticed that, you know, you're maybe being really negative recently and that's not like you, or whatever that is, and just being curious and listening. So not going in with an agenda, but just listening to what they say, and speaking to them about what they have to say about it.
Amazing. Okay. Another question that's come through. I've been in practice for a long time and never felt too upset about any of the euthanasias. Does that mean that I haven't processed them? And is that a problem?
So that's actually something that I hear quite a lot from people, is this, I think because we talk a lot about mental health now, which is good, and we talk a lot about processing things and thinking about trauma and unpacking trauma, and all of those things are really important, but sometimes it lends us to maybe think, like, questioning, are we okay if I actually feel okay? And there can be a lot of times in vet practice where we go through lots of these traumatic things and we can feel really upset about them and not kind of have to do any work to process them. There can be patients or clients that we really care about that we have maybe felt really lots of empathy for, and we've moved through that and we feel okay. It's only when we start to really start this shift in having more of a negative view of the world, a negative belief system, maybe it takes somebody to point that out to us, maybe it doesn't, that I would start to worry about it. I think if you feel really okay, it doesn't mean you didn't care. It just means that you have coped. You're all right.
Thank you, Katie. Another question. How can individuals speak to their managers about this? What training can managers or leadership go on? Do you think that would upskill them adequately?
Okay, that's a great question. So I think it would be really worth having a conversation with line managers, whoever you feel like it's best to approach with this. I think just like with any kind of CPD, I think it would be really nice to believe that we live in a world where actually, if we learn something on CPD, our practice is really open and willing to hear about it. So clinically, lots of places will be very happy to look at protocols and change protocols when it comes to looking after our patients. This is something that I think a lot of practices or organisations feel quite defensive about, understandably. So I think it's just about approaching the person that you think is going to be the most open to listening, maybe even saying, actually, do you know, I did this CPD and it's really opened up my eyes about vicarious trauma and actually some things that we could do that maybe don't even cost a lot of money, because things like implementing or giving people some time to have this group supervision or even one-to-one supervision wouldn't really cost the practices a lot at all, but it would absolutely pay back hugely when they've got a team who are feeling really, really supported by each other and really able to like take on anything that comes at them. So approaching them about it, seeing what they know about it, and offering to kind of talk about it, and broaching some of these ideas in team meetings even would be a good starting place.